Now, coming to our present day topic, that is how this ECG looks in different abnormal conditions. So, what are the different conditions that we can diagnose from ECG? Huh? Yes, we can diagnose. हाँ बताओ क्या क्या? हाँ 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 और हाँ heart blocks, good. Or so talking about the abnormal ECG, the abnormalities can be, okay, now just focus here. The abnormalities can be arrhythmia formation, okay, arrhythmia means disturbance of the rhythm, disturbance of rhythm. It can be disturbance in rate also, okay, there can be slow rate or faster rate, or there can be disturbance in rhythm. It can be either regular or irregular. So what can be the origin of this arrhythmia? So origin of arrhythmia can be, arrhythmias can arise from problems in, these are the different parts the problems can arise. So what are those? Sinus node, atrial cells in the atria, then we can have problem in the AV junction, and we can have problem in the ventricular cells. So these can be the areas where from this problem of arrhythmia can arise. So we can have sinus node, atrial cells, AV junction, and ventricular cells. Now let us go one by one. Let us go one by one. What can be the problems in the SA node? So what can be the arrhythmia problems in the SA node? So there can be sinoatrial block, or there can be sinus bradycardia or sinus tachycardia, right? So let us first see what is this sinoatrial block. So as from the name itself, you can guess that there will be some problem in the sinus node itself, sinoatrial node itself. So what happens that sinus impulse is blocked within the SA node. SA node either will not generate the impulse, or if generated, they will not be conducted to the other cells. They will not be conducted to the other cells. So absence of complete cardiac cycle, because when SA node will not generate impulse, or if it generates, the impulse is not conducted to anywhere. So naturally there will be no cardiac events. There will be no cardiac cycle, right? And it can occur irregularly and unpredictably, and usually present in young athletes, the persons who are on digitalis, it is a drug, okay, and in hypokalemia, or also in sick sinus syndrome. Sick sinus syndrome is sometimes the heart SA node does not generate an impulse. So all these conditions can give rise to no impulse at all. As you can see, this is called sinus arrest. Permanent sinus arrest is when person dies. When SA node permanently fails, or when heart itself permanently fails and there is no activity in the heart, so then that time it will be a permanent arrest. But in this case, the arrest is temporary. So you can say this is P wave, P, Q, R, S, T, and then there is no P wave, so one complete cardiac cycle is missed. Here also one complete cardiac cycle is missed, and then again it starts beating. So it is a temporary thing. Either SA node can start for maybe a few seconds like that, and then again it will start working. So this condition is called SA nodal block. Second one we said is about the so what can be the other problems? Other problems can be atrial. One is SA nodal block, one is sinus tachycardia, bradycardia, and these are some other things, other problems that can arise in atrial. We are just talking about atrial portion now. What can happen in the atria? So atrial cells can fire occasionally from a focus, or these cells can fire continuously due to a looping reentrant circuit. Looping reentrant circuit means that when the impulses go to the ventricles, normally they don't come back to the atria because of that non-conducting fibrous band between atria and ventricle. Sometimes there is an abnormal circuit, electrical circuit which arises within or between atria and ventricles. Because of that, these impulses which are going to the ventricle, they re-enter into the atria. So this is called a re-entry circuit. So because of that re-entry circuit, or somewhere a circuit is formed, impulse is going from one side and coming back from other side and again stimulating the same cells again and again. So that is what is called as looping. When you play some song on loop, we keep on loop, so it is going on repeating itself. So these impulses go on repeatedly activating the cells. So this is called looping reentrant circuit. So this can give rise to atrial flutter, and sometimes when the atrial cells fire occasionally from some focus, there can be some focus which is generating the impulse apart from normal SA node. Normally SA node is generating the impulse. Sometimes there is some abnormal focus present in the atria which is also generating a impulse. So that time, that beat, that electrical activity generated because of that focus, abnormal focus, will be resulting in PAC, that is premature atrial contraction. Why it is called premature? Because normally it will be SA node, but it happens before that or prematurely. So that is why this impulse generated from a ectopic, we say it as ectopic focus, apart from the normal SA nodal focus. So that impulse generated and conducted to the atrial musculature results in PACs, premature atrial contractions. We'll see how they appear in ECG, don't worry about that, but I'm just explaining the things. Then we have problems at the AV junction. So what can happen at the AV junction? It can fire continuously due to again some looping reentrant, okay? And we call this as PSVT, paroxysmal supraventricular tachycardia. It can occur in paroxysms, okay? Sometimes it occurs and then goes away. So we call this as PSVT, paroxysmal supraventricular tachycardia, because one is ventricular tachycardia. It is not happening in ventricle, it is happening at the junction. It is happening at AV node, AV junction, atrioventricular junction. So we call it as paroxysmal supraventricular tachycardia. The tachycardia which happens purely in atria, that we call as atrial flutter. We can call that atrial flutter. And then this AV node can also block the impulses. And in that case, we call it as simply AV junctional blocks. AV junctional blocks, right? Then further, so see, this is one of the examples of junctional rhythm. What do you see here? What is the problem here in this junctional rhythm? What do you understand by junctional rhythm? Junction is which? AV node. Okay, that is the junction between atria and ventricle. So what do you understand by junctional rhythm? Rhythm generated from AV junction. Okay, rhythm generated. So naturally, it will not have that normal P wave, because P wave will be normally there when the impulse is generated from SA node and it is normally conducted to the AV node. So because of that SA nodal impulse, atria goes into depolarization, and that is the cause of a normal P wave. Am I right? Am I clear? Here this rhythm is generated from the node. It is not coming from SA node. So naturally there will be no P wave, no normal P wave. So either the P wave can be absent. You see, there is no P wave. This is simply generated from the AV node. Or there will be an abnormal P wave that will come after this QRS complex. So this abnormally inverted P wave like that. So heart rate here is how much? How much big squares? 1, 2, 3, 4, 5, 6. So 300 divided by 6 is how much? About 40 to 60. And rhythm is regular. You can see rhythm is not irregular. And P wave is inverted, absent, or after QRS. Usually it is absent or it is after QRS and is inverted. And then rest of the things. So this is called junctional rhythm. Again, junctional rhythm will be generated when? When SA node will fail. When SA node will fail to generate impulse, there will be generation of AV nodal or junctional rhythm. So let us see at this rhythm. What do you see here? If this ECG comes to you, what do you see here? What do you look when you look at the ECG? Okay, and then there is a systematic way. You see, don't look haphazardly on an ECG. There is a systematic way, stepwise way to look at the ECG. So what are the different steps you look at how do you interpret ECG? Number one, rate, rhythm, then waves, PQRST waves, and then intervals and segments. So rate and rhythm, if you see first, so what is the problem here? What about the rate? Jaldi, jaldi, shabash, quick. 1, 2, 3, 4, 5, 6, 7, 8, about 9 squares. So what is the rate? About somewhere between 30 to 40. So what is the heart rate in this ECG? Between 30 to 40. And what about the rhythm? Is it regular or irregular? RR intervals are regular. RR intervals are regular, but only thing is that rate is less. What should be the normal rate? 60 to 100. 60 to 100 is a normal. Here it is about 30 to 40. So what is your diagnosis? Bradycardia. Bradycardia. And we call bradycardia, why? Because other waves are, P wave is there, so the rhythm is being generated from SA node, but at a decreased rate. Am I right? But at a decreased rate. So you can see here, there is normal P wave, isn't it? Normal P wave, normal PR interval, QRS complex, T wave, everything is normal. Everything is normal. So that is the rhythm is sinus. Only problem is that rate is lesser than the normal. So we go on. You see what is the rate? It is about 30. Regularity, it is regular, isn't it? It is not irregular. P waves are normal, right? And PR interval is normal, right? So QRS duration is normal. And the interpretation is what? Sinus bradycardia. ठीक है? अब इसका बताओ जल्दी से. What is the interpretation? Everything is normal except the increased rate. So what is the rate here? About 150. It is about 140 to 150. Hai? Two big squares are there, almost two big squares. So 300 divided by 2 is about 150, around that. So everything is normal. The rate is about 130, okay? And rest of the things are normal. So what is the interpretation? Sinus tachycardia. Right? Is it clear? Chalo aage fir. Number 3. What is the problem here? Irregular rhythm, right? Is there irregular rhythm? Yes, there is, okay? Some RR intervals are 3 big squares, some RR intervals are 5 big squares, okay? And P waves here you can see, this is a normal P wave, this is not a normal P wave, okay? This is a normal P wave, normal P wave. Rhythm is although regular, but rhythm is disturbed only when there is this abnormal P wave contraction. There is only one. Is there anybody else? No. Here also. So what can this be? This is premature atrial contraction. See, this is the normal. This is normal P wave, normal atrial contraction. This is normal cardiac cycle. Now next would have been here, but it is coming prematurely. So there is some ectopic focus which is generating the impulse. So that is why P wave is not normal. So this is called premature atrial contraction, and this sets again the rhythm. This resets the rhythm. Fir se yahan se, then again the rhythm becomes regular. This and this is equal. This is this and this is equal. Again a premature contraction comes. Again there is resetting of the rhythm. So the diagnosis here is PAC, premature. So rate is about 70, because you have to take in account the normal RR intervals, the regular RR intervals. So rate and everything. Regularity is, as I said, occasionally irregular. Whenever there is this ectopic beat, there is this premature contraction, that time the rhythm is disturbed, otherwise rhythm is regular. And P waves are, what is 2-7 different contour? P wave number 2 is different, P wave number 7 is different. Rest of the P waves are normal. So these two P waves are different because these are premature contractions. And the focus or the generation of the impulse is not from SA node, it is from some other focus in the atrial muscle which is generating the impulse, apart from SA. Is clear? Okay. So, ER interval and all is normal except in these premature contractions. So, our diagnosis is, what is NSR? Normal sinus rhythm. It is otherwise normal. Normal sinus rhythm with some premature atrial contraction. Is that okay? So, this is how you diagnose the PACs from an ECG. ये देखो ये this also shows premature atrial contraction, right? So these ectopic beats originate in the atria, but not from the SA node. SA node would have been a normal sinus rhythm. Okay. Therefore, the contour of the P wave, the PR interval, and the timing are different than a normally generated pulse from the SA node. Is that clear? Okay. Now coming to this rhythm, what do you see? What is the abnormality that you see here? Huh? Everything is normal except here. Huh? Everything is normal except यहाँ क्या यहाँ कुछ सब गड़बड़ है ना? There is no P wave and there is no recognizable QRS complex, isn't it? Okay, so let us see what is this. So what is the rate? Tell me the rate. 1, 2, 3, almost 4, more than 4 squares. 1, 2, 3, 4. So 300 by 4, around 70 to 80. Huh? 60. It says 60. Okay, if we be very precise, if we count the small squares exactly, it will give us the heart rate. So 1500 divided by small squares. So that gives us the heart rate of 60. What about the regularity? It is otherwise regular, only disturbed at this abnormal complex. Occasionally irregular. Only here it is irregular. Okay. And P waves. Okay. None for 7th QRS. There is no P wave for this one. Yeah, na? One QRS, 2, 3, 4, 5, 6. For 7th QRS complex, there is no P wave. That is what it says, none P wave for 7th QRS. Is it okay? PR interval is normal in all the complexes, in all the cardiac cycles. And QRS duration is okay, isn't it? Normal QRS duration, normal, and this is altogether abnormal, this one, okay? So what is the interpretation? What can it be? What can this be? Any idea? Sinus rhythm with premature ventricular contraction. Jaise premature atrial contraction, this can be a premature ventricular contraction. With an abnormal QRS complex, no P wave at all, okay? There is some ectopic focus in the ventricle which generates the impulse and is conducted to only ventricles. Obviously, it will not go to the atria. So only there is some abnormal QRS complex, because QRS complex is because of ventricular depolarization, okay, isn't it? QRS complex is because of ventricular depolarization. Here the focus is abnormal. It is not coming from the SA node. It is somewhere generated in the ventricles only, so it will give an abnormal QRS complex. And then the rhythm will be reset, again the ECG will be normal. So, okay, so what is the difference between premature atrial contraction and premature ventricular contraction? In premature atrial contraction, QRS will be okay. Or there will be some recognizable QRS complex and it will be preceded by an abnormal P wave. P wave will be there but abnormal. In ventricular premature complexes, there will be a total haphazard ventricular QRS complex, not a recognizable one. Right? So we have PACs and we have PVCs, premature atrial contractions. These are all occasional, and premature ventricular contractions. ठीक है जी? So you can at least have some idea about how they can be diagnosed from the ECG. It is not easy to diagnose all these things, but with time, when you go on seeing many ECGs on the clinical side, with the time, with the practice, it becomes more and more clear how to diagnose from the ECG. Okay, now this is the ventricular conduction. This is normal. Okay, this one is Normal, it comes from SA node and then goes to the atria, then goes to the AV node, then goes to the bundle of His, then it divides into right bundle branch, left bundle branch, and then the conduction is to the ventricular walls, and then it goes back towards the base of the heart. This is the normal signal moves rapidly through the ventricles. It goes quickly because of the presence of Purkinje fibers, which have the highest conduction velocity. The signal transmits quickly through the ventricular wall. So here what happens? Signal moves slowly through the ventricles, okay? So there can be some problems in the bundle branch or like that. So this can be one more issue when the this impulse is conducted through the ventricles. Now these conduction problems can be diagnosed into blocks, AV nodal block. So we have first degree, second degree, third degree AV block, right? So till now, what abnormal ECGs we saw? SA nodal block, okay, SA nodal block where there will be no cardiac cycle at all, right? And then we saw sinus bradycardia, sinus tachycardia, junctional rhythm where we don't have any P wave, okay, the rhythm is generated from the junction, just a QRS complex, may be followed by some abnormal P wave. And what else we saw? Premature atrial contraction, premature ventricular contraction, right? So these are the things we saw till now. Now let us move to the blocks, commonly called as hard blocks. So we have first degree, second degree has two types, type 1 and type 2, and then we have third degree, or which is also called as complete hard block, right? Okay, let us go one by one. Is it all clear? Any doubts till now? Okay, let us move forward. Now tell me about this rhythm. What is the problem? See, if we, again, whenever you try to analyze ECG, go stepwise. So rate, rhythm, then P wave, QRS, T wave, then PR interval, then QT interval, and ST segment and all. Okay? So this is how you don't jump, don't try to recognize something abnormal immediately. Just try to go through these steps. First see the rate of the ECG, then rhythm of the ECG. Is it regular rhythm or an irregular rhythm? Is it generating from SA nodal? Is it sinus rhythm or not? Is it ectopic rhythm? How do you say that the rhythm is sinus or not? How do you say that this is a normal sinus rhythm? There will be a normal P wave, as simple as that. There will be a normal upright P wave followed by a normal QRS complex. Normal upright P wave followed by a QRS complex. So we say that the rhythm is being generated normally from the normal pacemaker of the heart, that is SA node, sinoatrial node. Okay, so let us go stepwise. So first is rate. Rate is 1, 2, 3, 4, 5. So how much? 300 by 5, about 60. Roughly 60, or maybe lesser than 60, because it is slightly more than 5. Rhythm is regular. Rhythm is regular. Is it sinus rhythm? There is a normal here, P wave followed by QRS complex, P wave followed by QRS complex, upright normal P wave followed by QRS. So we say that this is sinus rhythm. We say that, am I clear? Normal upright P wave followed by a QRS complex. So here we say that this ECG is showing normal sinus rhythm, okay, with a rate of around 60 beats per minute and a regular rhythm. Okay, till now all is normal. Let us proceed further. P wave is normal, QRS complex is normal, isn't it? T wave is normal. So all the waves are normal. ठीक है? उसके बाद क्या? After that, intervals, PR interval and QT interval mainly, and ST segment. Let us see PR interval. PR intervals, you see how many squares? 5, 6, 7, almost 8, 9 squares. So is it a normal PR interval? No, it is a prolonged one. Normal is maximum up to 5 small squares. Normally 5 small squares should be normal PR interval, but it is more than that. So you can see here also, starting from here to here, almost 10 squares. So what is our only diagnosis in this ECG? Prolonged PR interval, and that is called as first degree heart block, type 1 heart block. So type 1 heart block, the ECG presentation is nothing but prolonged PR interval. And that is because there is increased AV nodal delay. The AV nodal delay has increased. It is not a normal delay of about this much time. Okay, so quickly you go, how much is the rate? 60. Okay, regularity is regular, right? And P wave is normal, PR interval is prolonged. It is 0.36. Limit is 0.2. Maximum it should be 0.20 seconds. So it is more than normal. And other things are normal. QRS duration is normal. It is a normal duration. So what is the interpretation? First degree heart block or type 1 heart. First degree atrioventricular block. One block is SA nodal block. That is different. SA nodal block is block at the SA node only. Here the impulse is generated from SA node. It reaches the AV node, but there is a delay in the conduction in the AV node before it goes to the ventricles. So there is undue delay. That is why this is called as first degree AV nodal block or first degree atrioventricular heart block or okay, this is first degree. Now going to the second rhythm. Again, this is first degree. What can be the cause, etiology? Prolonged conduction delay in the AV node, as I said. So coming to this rhythm, what do you see here? Again, stepwise. Don't jump to the. I understand. You see there is some abnormality here, but don't jump straight away to that. Go stepwise. What about the first thing? First thing. What about the rate? If you see this one is something abnormal, so don't count this. We count this is normal, this is normal, this is normal. So how many squares? 1, 2, 3, 4, roughly 5 squares. So what is the rate? About 60. Okay, so rate is 60. Second thing we see is, what about the rhythm? Occasionally, only here we can see some irregularity, otherwise it is regular. Then third thing is sinus. Is it sinus rhythm? Yes. There is a normal P wave followed by a QRS complex. So it is a sinus rhythm. That means it is important. That means rhythm is being generated from normal pacemaker, that is SA node. So this is normal. Then coming to the PQRS T waves. They are all normal. All waves are normal. P wave is normal, QRS complex is normal, T wave is normal. Now again coming to the intervals. What about the interval? What is the finding here? Let us start from first. This one is normal. This PR interval is normal. This is prolonged. How many squares? Say about 7 squares. About? How much is this? About 10. Ab dekh rahe ho? So this is normal. This is prolonged. This is further prolonged. So in subsequent cardiac cycles, there is prolongation of PR interval. You get it? So suppose first it is more than 5 squares, about 8 squares. In next beat it is 10 squares. Then in third beat it may be 15 squares. Fourth beat it will not be conducted at all. So you can see after this there is prolongation of PR interval. This one. So there is prolongation of PR interval. Then this is the P wave. This is the P wave. इसके बाद क्या है? और एक P wave. There is another P wave. That means there is no QRS complex after this P wave. That means this P wave has not been conducted at all. Any doubts in this? So what happens in this? There is a prolongation. Okay, there is a consecutive prolongation of PR interval. It goes on prolonging from one cardiac cycle to another till the beat is not at all conducted to the ventricles. there is complete AV nodal block. And then again it starts, after that again it starts conducting, then again it will start prolonging, and till maybe third or fourth beat will be not conducted to the ventricle. So you can see here, this is PR interval, this is prolonged, further prolonged, and finally this P wave is not conducted. There is no, why do we say it is not conducted? Because there is no ventricular complex after this. And after this, there is this pause is called compensatory pause. This is called compensatory pause, and then finally another P wave comes and the same phenomena repeats. Same prolongation of PR interval. Finally, again here, there will be a missed beat. The beat, the impulse will not be conducted to the ventricle. This is called type 2 second degree heart block, but type 1. Type 1, Mobis type 1. We also call this as Wenckebach's phenomenon. We also call this as, so what is Wenckebach's phenomenon? Subsequent prolongation of PR interval followed by a non-conduction of impulse to the ventricle. So let us see quickly. Rate is 50, regularity it is regularly irregular, right? Regularly irregular means what? What do you mean by regularly irregular? See here, see what happens here, 1, 2, 3, 4, 5. Because here PR goes on prolonging, so this will also go on prolonging. And finally here you can see so many boxes. This irregularity will repeat itself. Got it? So this irregular pattern will repeat regularly. समझ रहे हो? Here we have 1, 2, 3, 4, 5. Here we have 1, 2, 3, 4, 5, and maybe little more. Here we have 1, 2, 3, 4, 5, 6, 7. Again it will repeat 5, 6, 7. Again it will repeat 5, 6, 7. That means there is irregularity but repeating regularly. That is why it is called as regularly irregular. One thing is called irregularly irregular. Uska koi pattern, there is no pattern. It can come some beats after 2 square, some after 5, some after 11, some after 1, irregularly irregular. But here it is a regular pattern. What happens? PR interval goes on prolonging and a missed beat. Again it is going on prolonging and a missed beat. So there is a regular pattern, although the pattern itself is irregular. Okay? P waves are normal, there is no problem. Okay? Except this one where there is no QRS complex. Only this P wave is not followed by QRS complex. PR interval goes on lengthening, goes on increasing, okay, from beat to beat. And QRS duration is, what about QRS duration? Normal. कहीं पर आपको abnormal दिख रही है? नहीं. All QRS durations are normal. And what is the interpretation? Second degree heart block has two types, Mobis type 1 and type 2. This one is Mobis type 1 block. First degree heart block is simply more than normal PR interval. In every beat there will be more than normal PR interval. In second degree heart block type 1, there is subsequent prolongation of PR interval till one beat is not at all conducted. And then the cycle repeats. Also called as Wenckebach phenomenon. Wenckebach phenomenon. Sometimes this pattern can be dangerous. It can change into ventricular arrhythmias. Wenckebach phenomena, it can result in ventricular fibrillations, which is a dangerous situation. Okay. What about this rhythm? What is the problem? Rate, rhythm, PQRST complex. Okay, let us again concentrate because we are dealing with blocks. Let us concentrate on P wave or PR interval or like that. What is abnormality? So what do we see quickly? What is the finding? Heart rate, okay, leave the rhythm. What is the QRS complex? What about QRS complex? Beat drop हो रही है, huh? There is some beats are not conducting. Is that the finding? Is that the finding? You see, this P wave is followed by QRS complex. So normal, it is conducted. ठीक है? This P wave is not conducted. Do you recognize this is a P wave? You know, this is one complete cardiac cycle P QRS T. Again the P wave comes, but there is no QRS complex. Again the P wave comes, there is no QRS complex. Again the P wave comes, but there is a QRS complex. Again this P wave is not conducted, this P wave is not conducted, this one is conducted. This is not conducted, this is not conducted, this one is conducted. So what is happening here? Some beats are being conducted to ventricles, some are not. As simple as that. So इस ECG में क्या हो रहा है? In this ECG, two beats are not conducted, third one is conducted. So we will call this as 2:1 block. Sorry, 3:1 block. Out of 3, only 1 is conducted. Out of 3, only 1 is conducted. तो इसको कहते हैं हम Mobis type 2. And it is a subtype of second degree heart block. Is that clear? So this is second degree heart block type 2. Second degree AV heart block. You have to add all these things. Huh? Second degree atrioventricular heart block, Mobis type 2. Okay, Mobis type 2. So, second degree AV heart block type 2. Then comes so what is this? Occasional P waves are completely blocked, as I said. And then comes this one. Okay, so we have type 1 AV block. What is the finding? What is the ECG finding? Only finding is PR interval is more than normal, more than 5 squares, more than 5 small squares. Second degree heart block has 2 subtypes. Mobis type 1, Mobis type 2. Mobis type 1, subsequent prolongation of PR followed by a non-conducting beat, right? Also called as Wenckebach phenomenon. Mobis type 2, some beats are conducted, some are not. It can be 2:1 block, 3:1 block, 4:1 block, like that. Okay? Some beats are conducted, some are not. So AV node, it conducts some beats, it doesn't conduct some beat. Now coming to this ECG, what is the problem here? What is the rhythm? Rhythm is normal, almost showing normal rhythm, huh? And rate. What is the rate? कितना है? Calculate the rate. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. 300 by 8. Huh? 30 to 40. So heart rate is between 30 to 40. Right? So 30 to 40 heart, if there is an ECG of 30 to 40 heart rate, so why don't we diagnose this ECG as sinus bradycardia? Tell me. Huh? Because there is no normal PQRS configuration. We could have called it as sinus bradycardia, but the term is sinus. Sinus means normal sinus rhythm. But there is no normal PQRS configuration in this ECG. So we cannot call it sinus bradycardia. Now we have to concentrate, the rate is less, very less. Okay, normal should be about 60. Here it is about 30 to 40. What is the other abnormality that you see here? What about the P wave? This P wave, it is not followed by QRS complex. Here there is another P wave. Here there is another P wave, another P wave, another P wave. So what we say here is there is no coordination between P and QRS. Sometimes you see, sometimes the P wave is coming immediately after QRS, isn't it? And another P wave is here, another is coming here. Then there is this is called a dissociation. This is called dissociation. There is no association between P wave and QRS complex. One abnormality is this. Second abnormality, there are no normal QRS complexes. There are no Is it a normal, does it look like a normal QRS complex? It doesn't look like a normal QRS complex. So let us find out what the problem is here. So what is the rate? Rate is about 40. Okay, as you said, 30 to 40. Regularity, it is regular, but rate is less. But rate is less. And what about P waves? You see, there is no association between P and QRS complex. Okay, no relation to QRS complex. ठीक है ना? They are occurring independently. They are occurring independently, right? PR interval, because there is no recognizable R wave. There is no normal QRS complex here, so we cannot call this as R wave because it is not a normal QRS complex. So we say there is no PR interval here. There is, or we can say there is no recognizable PR interval here, right? Then QRS duration. What about QRS duration? You see, it is more than 2 squares. So we can say these are wide QRS complexes. These are wide ventricular complexes. Wide ventricular complexes. What is the interpretation? Why is it complete heart block? P waves are occurring. SA node is working fine. Okay? SA node is working normally. SA node is working fine. SA node is generating the impulse. Because of that, atria is getting depolarized. So there is a P wave. There is a normal P wave. Once this impulse reaches AV node, it is not allowing at all. It is totally blocking this. There is complete AV nodal block. So the impulse is not going to the ventricles. ठीक है जी? Impulse is not going to the ventricles. Now, ventricles, once they don't receive the impulse, what will happen? As we have discussed the conduction system of heart, we have SA node, we have internodal pathways, we have AV node, we have bundle of His, right bundle branch, left bundle branch, Purkinje fibers. So once AV node is not allowing any SA nodal impulse, there is a complete block. That's why this is called third degree heart block, also called as complete heart block. There is no transmission of impulse from atria to the ventricles. So ventricles, after waiting for some time, either the bundle of His will generate the impulse or the Purkinje fibers will generate the impulse, but their rate of generation of impulse will be very less as compared to the SA node. And now when the impulse is generated in the ventricles, either from the bundles or from the Purkinje fibers, so naturally the impulse is generated in ventricles and it is transmitted. So the path of conduction is not normal. That is why the QRS complex will not be normal. ठीक है? QRS complex, the Q wave, the R wave, the S wave, they are normal patterns only when the impulse travels through the normal path. Through the normal path, when it comes from SA node to AV node, then to bundle branch. Here, maybe this impulse is generated in the ventricular walls, at the apex, or wherever. So impulse is coming in the reverse direction. Maybe we can say that. So we don't expect a normal QRS complex. Is that clear? Normal, typical QRS complex will be only when the impulse is generated from SA node to the AV node to the ventricles, That is why here the QRS complexes are wide and haphazard. They are wide and haphazard. So what is the diagnosis? Diagnosis: third degree atrioventricular block or complete heart block. और complete heart block. Okay, तो इसमें एक हम problem discuss करते हैं that is called as Stokes-Adams syndrome. I think told you before this also. What happens is there are certain paroxysms of this, complete heart block. Okay, and what happens when suddenly the AV node fails to conduct impulses for a longer time, for a longer duration. Okay, and when the AV node stops the impulses, So naturally, ventricles are not getting any impulses, they stop functioning. They stop functioning means they are not contracting. So the status remains for some time, maybe minute or more than a minute sometimes, till the AV node starts its own impulse, or till the Purkinje system starts their own impulse. So this gap, when the AV node stops, there is complete block and the generation of ventricular complexes. In this gap, there is no cardiac output. Ventricles are not pumping the blood. So the most susceptible cell to lack of oxygen is your neurons. So maybe, and during this period, the patient may faint. He faints till this beat is generated again and cardiac output is again resumed, and this phenomenon, this syndrome is called as Stokes-Adams syndrome. So how will you like to treat this condition, which the person which is having this complete heart block? Usually we do it by fitting a pacemaker, which is called an artificial pacemaker. And there are different types of artificial pacemakers that we can discuss sometimes. So there's an externally operated battery which is connected to a heart, which generates these electrical impulses at regular intervals, and the heart beats not because of nodal impulse, not because of any impulse, but the heart beats as per the impulses generated from this artificial pacemaker. Then different artificial pacemakers have different lifespans. That's a different topic together. Okay, so today there are many more abnormal ECGs that we can discuss, but today we will just stop here. Okay, so we have discussed some abnormal ECGs. There are many more dealing with atrial arrhythmias, ventricular arrhythmias, myocardial infarction, bundle branch blocks and all. Inshallah, we will do that in our next class. Okay, and today, if we quickly recall the points, what are the abnormal ECGs we discussed? One is SA nodal block, sinus tachycardia, how to recognize sinus tachycardia and sinus bradycardia. More importantly, how to recognize sinus rhythm or ectopic rhythm. You should be able to recognize difference between a normal sinus rhythm and an ectopic rhythm, right? And then we saw the ECG of premature contractions, premature atrial contractions, premature ventricular contractions, and also junctional rhythm, okay, nodal rhythm. And then we discussed about the AV nodal blocks, or commonly called as heart blocks, which are of three types: first, second, and third degree. And second degree heart block has further two subtypes, that is type 1 and type 2. So quickly, if we'll go through this, okay? So that's all for today. Thank you. Thanks a lot.